Welcome to our latest episode of the Lebanese Physicians Cast. And today our guest is Dr. or Professor Glenn Geelhoed, who was a prominent surgeon at GW Hospital and then has worked in Africa for a long time. The title of our podcast will be Healing the World, Then Becoming the Patient. We will talk about his journey with multi-drug resistant tuberculosis, his running journey, and the purpose. He has, for more than 4 decades, Dr. Geelhoed has brought medical students and surgical care to some of the world's most remote and underserved communities through Mission to Heal, which is the NGO that he's developed. Along the way, he has inspired thousands of future physicians, and he's trying to inspire me to go with him to help build sustainable healthcare capacity across Africa and beyond. But after a lifetime of caring for patients, Dr. Geelhoed faced a challenge of his own. He was diagnosed with multi-drug resistant tuberculosis, and we will discuss today his deeply personal journey with this disease and how he dealt with it and how it affected his running and his Mission to Heal work that he's done. And we explore the lessons learned from that. Dr. Geelhoed, welcome to the podcast.
Thank you, Khalil. And this is a recruitment interview, I'm sure. Not for me, but for you. We'll get you out there, I guarantee it.
Yeah,
It's
yeah.
more habit-forming than crack cocaine.
So Glenn, can you tell us what first inspired you to create Mission to Heal, and what problem were you trying to solve when you did that?
I was a Midwestern-born young fellow and enjoyed some of the things that I had seen in school. Perhaps it started as early as sitting on the floor of the library and pulling out the National Geographic when it was still black and white and saying, who are these people and what are they doing and how is it that I'm living in this one room of this magnificent mansion and haven't gotten out of this one? And I'd always wanted to see them. I was fascinated with the sciences, but there was no carrying capacity on the other side of that. And I wanted to apply this in some fashion, that there was a humanitarian benefit that came from this. How could I do that in some way? Doing that was really in medical science, and I pursued that, which allowed me the luxury of literary and the philosophic aspects of it, which would otherwise be like eating dessert all day. I had to have a purpose for doing what I was doing, as we all do. And that's how I got started, first of all in medicine, but also in those who had the least advantages, who could have benefited from it most.
And you've done great. You've done this for about 40 years approximately, right? What are some of the most memorable experiences from your work in Africa in that period?
You've got it right there, but a little bit short. I think I just celebrated my 57th year in
Wow.
Africa.
Wow.
Otherwise, I had done each of the other continents as well. So I had actually begun in places such as South America and also persistently returned to Africa, which is, I am African in the sense that my heritage is perhaps 5 or 6 generations American. My European ancestry is maybe 5,000 years, but for 5 million, my genetic predisposition has been wandering that great Rift Valley. So if you take everything from my microbiome to my genetic predisposition, I am much at home when I am there. And yes, I had done that for a period of time, identified very closely, especially with those who have insurmountable prospects ahead of them without any of the resources that we seem to have been smothered with. In your case and in mine, we have both been the products of, let us say, redundant societies in which there's been room to make even errors and still come through them. In this case, they had to do 2 things. They had to, maybe 3. They had to deal with bigger problems in larger numbers with far fewer resources, a skill that I didn't have, coping without any of the kinds of advantages we have from borrowing from others. So I wanted to know what made that happen. And I know there is no society on planet Earth that doesn't have a healer, a go-to person. They may not have a hospital, they may not have an intensive care unit. They certainly probably do not have endoscopically directed, minimally invasive preventive things of one sort or another. But they always have someone who is going to take upon themselves the responsibility for the care of another. That is the only fundamental inside medicine, is that assumption of responsibility. It shares that with a number of other professions, of course, but in this case, what other reason would you be getting out of bed at 3 a.m. to come and see a patient ahead of your own interests and in favor of what you might be able to do for them? I wanted to know what these people knew that I didn't, how to take care of these bigger problems without all the testing and all the other components that I had around me from my medical school and later my academic medicine training. So I'd done it as an experience, and the experience was so rewarding. It wasn't transactional in the sense that I think you and I can both use that term, that I learned 4 new things by going on a mission. No, that I probably learned in biochemistry or something like that, and I knew the Krebs cycle at this point, and I could move on to the next one and admire on. No, this was transformational. And I looked at that with the rest of my students and the others that have gone with me. And I realized it's happened with them, invariably. And it wasn't I, the encounter with me, that transformed them. That would have been the case, I presume, if I were a professor in the medical school, because they would met this fellow and he directed our paths in one direction or another. Now, these were those subcultural giants that I encountered. People who had never been inside a classroom and could teach each of them as well as me. And I wanted to be able to learn from them and take some of that on and quantify that experience in such a way that I could multiply that, have it done with other people. And I've studied that fairly significantly in the sense that I was serious about it. And I tried to find out, what about this experience changes lives? I'm sure that I had an aha moment when I was studying something in biochemistry or in anatomy, but it wasn't life-changing. It was transactional. Once you encounter one of these subcultural giants who has absolutely no reason whatsoever to be enjoying life, having just lost a husband from some unknown wasting disease she didn't understand, having had 5 of her 7 living births died before age 5, and having a number of dependents upon her that were part of her immediate bloodline. And she looks upon the students that are with me, and they're all full of vim and vigor, having just passed their prelims or whatever it was that got them to this point. And then they're saying, I'm here on this white horse, and I'm to take care of you. I recognize that they have no idea how to do it. It takes all the wind out of their spinnaker when they hear this woman, through translation, say, how can I help you? And I find that is that transformation. It is not an encounter with me, it is an encounter with one of those. And recognizing that patient and that illness, how they part company in our presence, whether or not from our actions, may be subject to some doubt. But the caring aspect is there. We misallow that because I think in this history, we have never on this point in time ever been able to do so much for so few who are so little satisfied with the results. And here, when we do what we would consider nothing, meaning that we didn't cure your cancer, we did not take away your disability, they come back and are grateful for it. So that transaction is that which transforms. It was true in my case, and that's 540 missions ago, and I watched it for each of those students subsequently. I even tried to quantify it in a thesis and say, in this encounter, how has this changed? And we're working on the qualitative aspects of this, and that's a work in progress.
Exactly, and that's important, I think, to see, because some people say these missions, sometimes they help, sometimes they don't, but I think they make a huge impact, probably both on the people who are there and on the people who are treating them, because then you learn that you have to do with much less resources and help the patients who are there in that area. So from that, I was going to ask you, look, before we start talking about your journey with tuberculosis, was how many, so you said you've done 540 missions, how many students and physicians have gone with you throughout these missions, and which countries have you had your missions in?
The number crunching I have left to others, and there are bean counters who have been with me, and they have said, I have taken 1,720, at least those are the names and addresses that we were able to retrieve by email and otherwise, to whom we have asked in subsequent years, how has this changed you? And we wanted to see the durability of that change. And if there ever is going to be something written in granite as an epitaph, it would be not a single one of them has not gone back. So as I say, this is dangerous for you to be invited to come along with me because it's going to be a habit-forming event. It is so rewarding that it is not something, the recidivism rate is 100%. So you will find from the experience a lot more reward. When you say it's a two-way street, I'm quite able to measure, at least in my own estimation, what it's done for me because I keep going back. For those that I've watched, it has been the same.
Right. And so you've been through all of this, the mission to heal. You also, what people don't know is you've been a avid runner and actually marathon runner, having run a lot of marathons over time. And actually last year you were on the verge of running your 50th Marine Corps marathon out of 50. And while you were training for that, you started developing a shortness of breath, and you're like, why is that happening? And that led to an x-ray which showed inflammation on your lungs on both sides, and then a diagnosis of tuberculosis. So after decades of caring for patients, what was it like to receive your diagnosis of tuberculosis?
You caught me. You got me in the right mode there. This is a number I have crunched. I do know, and there's no runner on the planet who doesn't know how many marathons and what their time was on their best or their PR or their worst or whatever. Those numbers I still do retain. What I had done was consistently throughout my life. One of the wonderful things about being in Africa particularly is that here I am right in the cradle of mankind in the Great Rift Valley. And I get up earlier than most. That's about an hour before dawn. There are no other things to distract me. And with a headlamp, I get out of my mobile surgical unit and I start off on a run. There is no one stirring. And in fact, the only things that I bump into, and I'm careful about how I do the bumping in, are the belly rumble I hear from the elephants, who are very respectful of my presence, and I even more so of theirs. So I don't shine the light in their direction. I don't threaten them in any way. And I listen. And I have listened to the birds come alive 1 minute before that dawn, and then a cacophony at the first rising of the sun right on the equatorial African plain. I love it. I've been doing that regularly. And then at the time I was doing it, I said, there's a particular run out here. I'm going to make this one happen. I've tried several times, and my mission either overlapped it or was about to leave and went 3 days before the event. These are the mountains of the moon. These are the volcanic origin of the great shield volcano that is the central part of the African continent. It's got various names. Sir Richard Burton called them the mountains of the moon. He is actually the one who was the first European to put eyes upon it. If you are Francophone, you would call them Ruhengeri. If you are Anglophone, the name there is the Ruhenzori. By whatever name, it's a series of volcanoes right along the 0-0 line of what later became Ecuador, the equator. So I was setting out to do the Ruhenzori Marathon. Now, it's now the 5th year in a row, and when you and I go out to Africa, I'm going to make sure that they can see that at least one other white man is running. I want you to do that. Not to say that we'll be in the first 10, because these folks who have never run in the race never had a bib placed upon them. I see them only from the backside very shortly after we begin, because first of all, they are altitude bored. I thought maybe that's the reason I'm not making any records up here, is at 6,980 feet altitude. And I've been working for a couple of weeks in that same altiplano. Nonetheless, I said, hey, there must be something about this. Coming back from that, I went down to South Africa, another spot that was at elevations above 7,000 feet. And during my night in a tent, sitting out there in the Limpopo region, I had what I just know is classic. I've never had one before, and this is the first of my life. a night sweat. I was wondering, why am I drenched when I'm at an altitude such that it's not hot enough to do that? I'm not even under the mosquito net because there's no self-reflecting anopheles that lives at that level. I then said, maybe I'll have a check-in on this. Maybe there's something to this. And I came into my return. Remember, I'm doing a lot of running because I'm prepping for the number 50, big one. And they call me the last man standing. And for that reason, since I've done them, and they know me pretty well, they're all looking at me saying, okay, just wait till you see this. And I'd been inducted into that sometime earlier, and they were all making a lot of predictions about this. And I said, maybe I should check in on this. I'll write myself a chest x-ray. Not because I have any cough or not because I have any production of fuel. I don't know. Maybe it's just a good idea because I had taken care of a number of people who had severe wasting disease, who had night sweats, not only, but fever and also were coughing blood. And I said, this is not a diagnostic dilemma. Let's get them started. The one woman I did this in the Great Rift Valley, a little town called Tuberculosis, which has no facilities. And I said, aha, I know just where I got this. This is a probability. Maybe I ought to check because I didn't wear a mask or anything like that. But I wanted to get her tested, so I wrote up a script and I said, we're going to get you a Zil Nelson, ZN. I'm going to get you a chest x-ray, which of course, village, it has no electricity. There's no starter. And we're going to get you a sputum for not only the smear, but also the culture. How will we do that? That's in Marsabit, which is the county seat, which is 4 hours away. They use or they call it piki-piki in Kiswahili, but both is the language that we're using there. Getting on the back of a motorbike. I saw her 3 days later and I said, what's the result? She said, oh, of course. It's her translation. She didn't go. She didn't have any money to go. Okay, then here. So we gave her the number of shillings that are required to get her on a boat and get her up there. And I saw her 5 days later. Okay, what are the results? She looked quite content because, after all, she had shillings. What did she do? She went straight to the market and bought food. The only rational response anyone should have. I would have done that myself. So I said, okay, come along. And we got her into my Land Rover, which is a Toyota Land Cruiser, which is an open trunk, really. Drove her up there. It was a long way, and I was sitting next to her, and we got up there, and we got her studied. And sure enough, no question about it, she's got a positive smear, a positive culture, a positive test. Everything about it is classic. So we get her started on first-line therapy, and we bring her back to Ultrat. And I thought of that while I was running the Ruwenzori Marathon, not my PR. And I came back and I said, maybe I should have chest x-ray. And I don't want to prescribe it myself. The physician, as himself as a patient, has a fool for a physician as well as a patient. And I said, here, I'm part of the VIP clinic at GW. I think that stands for very insecure people. So I said, I'll just call my friend Joel and say, so Joel Willis, who is my primary care doc, and he said, sure enough, I'll write you the script for the chest x-ray. And I was feeling pretty good upon return. I thought, see, it was only the altitude. And I was putting on 80-mile weeks to get prepped for number 50. And not to tell you that I had just said I didn't do much number crunching, but that would have been number 185, approximately, in my marathon list. And I said, okay, we'll see. No, I'm doing fine. So I bagged the x-ray. I did not come in as it was written. They didn't have a date on it. I had to call for the appointment. After I did that, I said, I can't disappoint Joel because he's asking me what's the result of the chest x-ray. So I then scheduled it. I came in. I then got both the chest x-ray, and at that time, when I was in GW getting the chest x-ray, I stopped at the clinic and did sputum, which was difficult because I didn't have sputum, for both the smear and blood test that was not really part of my original text. I don't do skin testing. I figured that wasn't as accurate as what's coming up next. And then I went out running, and I think that's when I met you by phone. So I was on the ICC county connector here, and you could hear the noise in the background when Joel called me. And he said, what's that noise? And I said, Oh, I'm sorry, I've got a little interference here because there's traffic. He said, you're running? I'm going to send you a copy of your chest x-ray. How are you standing? And so I said, okay, now walk back to your car and then sit on the couch until we get this thing under control, and we'll get you referred over to the Maryland, Montgomery County Tuberculosis Control Center, and we'll have you, because smear is positive, the culture is positive. And by the way, those two positivities were the only ones I've ever had. Immediately upon starting therapy, I've never had another. And so here I am, given a diagnosis, and they said, and don't run. This is something I'd like to have you hear and see how your response is the same as mine. And then Joel immediately said, I've made an appointment with you for a pulmonologist named Dr. Fadil Diab. And by the way, he's a runner. He'll understand. He's never going to tell me not to run. I know that. So I saw you immediately thereafter with both the positivity of the chest x-ray and of the smear, and much later reported the culture. All of this sounds pretty garden variety. It would sound like, okay, that's good news, because that's a treatment that we have pretty well perfected, and we'll take that, we'll be done with it, we'll be on our way. I don't think it will be ready before marathon number 50, but what the heck, I just ran through Missouri with whatever this stuff is, and so let's see, 6,800 feet higher. So I said, no problem there. And then when they said, okay, we're going to start you on treatment, and they did, first-line therapy, your urine is going to turn bright red because of I know that. I know all of the other stuff that's in there and the different the 5 drugs. And then immediately thereafter, they called back and said, but you're famous. I said, this is the last thing you want to hear as a physician, that you're dying of something interesting. Never do that. Get the most garden variety plain vanilla you could possibly have, because it was resistant to 3 out of the 5, and therefore they were going to give up on the first line and start the second line, which they did on weekly trips there, sputum each time, blood work each time. And within 2 weeks, again, they said, are you still sitting on the couch and not doing any running? Yeah, I was perfect in my compliance. I took on, first of all, with a visiting nurse, and then on VDOTS. As you all know, DOTS therapy, directly observed therapy system, which I've assigned to how many people in my life, maybe a couple thousand, and sent out messengers to watch and do that. Now, this is on video. And they said, oops, of the new drug agents, a number of these are toxic. We're watching your blood chemistry change, your liver enzymes, your creatinine and BUN are not doing very well under this pressure. But we're going to stop that anyway and start you on some new agents because it's resistant to 4 out of the 7 of the second line therapy. So we're going to put you on B-Palm. B-Palm has got very good stuff. By the way, bedaquiline is highly expensive in the center world. We're going to have to see if we can find some way to get it for you. And I said, by the way, it isn't readily available. Could you write to Johnson & Johnson and see if we can get exemption? Which I couldn't, because I couldn't smile and say I was an impoverished patient needing to have compassionate need. And as a consequence, it took a little while, but we got it started. And so I'm on bedaquiline, which is, I don't have to explain to any of your audience, does a little thing like every cinchona derivative, anything that says quinine in it is going to have an SRT elongation of that repolarization on your EKG. So they watched, as mine went up into the very high numbers, they said, you're getting a little close because at 500 milliseconds you might fibrillate and you're up to 420. So we're going to see if we can't do something. By the way, don't do anything to increase your heart rate. Don't do anything that would be like, for example, running. No, don't do that because, of course, if you have a much higher heart rate and you have this prolonged SRT, you're going to have a little trouble. But we could resolve that. We could mitigate that by perhaps implanting a defibrillator, and so that you wouldn't have to worry. So I said, I'm going to undergo an operation for a side effect of medicine for a disease that you tell me is probably not very significant. It's always been suggested it's contagious. They said they're still studying it. It's been sent now to every reference lab everywhere around because it's an unusual soil mycobacterium that is unknown in the New World. It has never been seen in Europe or in North America. But it has once been seen in a conjurer that several DNA sequences are phased. Once in Nepal, some 35 years ago, and once in Mongolia, 15 to 20 years ago. When were you last in Nepal? When were you last in Mongolia? It turns out 3 or 4 trips, 35 years to 30 years ago in Nepal, and 3 trips, 15 to 10 years ago in Mongolia. They said, we have DNA sequenced this, and we find that it is 5 DNA specificities apart from that last one seen. But we're under a lot of pressure from both the World Health Organization. Remember, I had a couple of friends at CDC who were furloughed at that time. I don't know if they're back at work, whether or not that is ever because, but they were busily at work anyway, unpaid, trying to get sequencing on this because, in fact, they were writing it up as an organism that had not been seen in the world. So they said they would like to push this down to the point where it wouldn't be seen. Can you do 3 months under this kind of antibiotic pressure? I said, well, the killing part was not the medicine, that was the sitting on the couch. And we got to 6 months. They said, that's pretty good, but our recommendations are now, could you go for a year? I said, I don't think so. So we got out to 9 months, and that passed 2 glorious weeks ago. I feel a little bit like I'm sitting in an AMA meeting. Hi, my name is Glenn, and I'm 2 weeks drug-free. And they said, there's been no evidence of contagion at any point. The 29 contacts will be looked at, including those that you have taken care of that might have been immunosuppressed, have had 1, 2, and in one instance, 3 consecutive chest x-rays, as well as blood testing. And one of them even went so far as to have skin testing, as well as the sputum sampling, which of course was not necessary for any of them for culture because all of this was negative. No contagion evidence. And so they said, now you can discontinue. Oh, by the way, let's have you back if you want, and we'll see if your enzymes are still out of whack with your liver and with your spleen. They had me on a couple of other agents, one of which was cyclosporine, one of which, when the neuropathy started and I had a little imbalance that came from the nasal, which, by the way, had an Upjohn number on it 40 years ago when I was the head of the surgical research lab. So being in the lab, they asked me to test it. I said, it's not bactericidal because it doesn't accomplish a 2-log kill in 24 hours. It takes 36 hours to get that. And they said, okay, then we'll do it with bacteriostatic. I actually gave FDA testimony on the results of my early, before Pfizer bought Upjohn, and then Pfizer brought it into the market as linazolid. So I'm on the drug that I had once helped to develop. And number 2 is I am on the same agent that I gave for leprosy 50 years ago in the Congo and in other parts of the world. So that agent and I have been around for a half a century together. So I hope those agents collectively have eradicated the organism. At least it's not present unsmeared. That's too much of a biography of the bug and a little less about the biography of me, which is, yeah. I am very grateful, number 1, for your care and for that attentive follow-up, but also the fact that I look at the patients around me, and many of those have illnesses they will not get better from. All I'm doing is mitigating their evolution.
But saying that, Glenn, I think, we talked about the bug, how you were treated for it, and how difficult the treatment was. But when you were diagnosed at first, what were your emotions? You were getting ready to run your 50th Marine Corps. You were getting ready to go to a banquet, be recognized for that. And you also had, I think, multiple family events that were happening that summer. So it's disruptive and actually it prevents you from running. So what were your emotions when you were first diagnosed?
We'll give you one emotion that's very clear for both you and for me and anybody else who's listening here, because we all got here by being pretty hard-headed. We are purpose-driven, and we are not likely to say, okay, we take your very rational advice and we won't follow it because, after all, we know what we're doing. We're going to go ahead and do it. I was glad not to be in a position to say, let's see, should I or should I not appear for the 50th Marine Corps Marathon? I didn't have that opportunity because I surely would have. After all, I ran during COVID. I ran the battlefield marathon in Gettysburg with a mask, with the field limited to 100 people, which meant that you had a lot of people that wanted to do it. So they did it 3 consecutive days and had 2 people on the course. And there wasn't anyone handling out water. You had a water bottle there and you picked it up and you could wear a mask at the beginning, at the end, or if anyone was coming around you. So I was about to say, hey, we can do this. After all, I put on 80-mile weeks. I just passed 1856 on my training log. And I just told you I didn't do any number crunching. There's another number that I still have in mind. And I said, okay, we're going to do this. No, they said, you're not. You're not coming to the Hall of Fame dinner. And the reason you're not coming to the Hall of Fame dinner is that you have several guests that are coming. And those guests of yours are also celebrating 50 years, probably more significant than yours. And I agreed that they were. I had, during the timing of my first ever race, the other time I ever pinned out a bib, I was looking around in Washington, D.C., having run around places like Teddy Roosevelt Island, the Mount Vernon Trail, and trying to do this while daylight was on, as you probably get there before sunlight and you get there much after the sun set in much of your year. So I'd do this in the middle of the day and take a shower over in the wellness center, and then I'd go back to work. Well, the fact was, I saw that there was a sign saying that there's some kind of race going on here that was coming up in October. And I thought, the Marines are doing it, and I'm not a Marine, but maybe I can find out more about it. And so, having gotten into that race the first time I pinned out a bib, I did what you probably did on your first run, too. Or the first time I climbed a significant mountain, or the first time I did anything in my life. I am flat out done. I have given it my all, and I certainly can't go another step further. Wait a minute. I recognize this. I know this feeling. It's happened to me before. What did you do then? I sucked it up and I kept on going. Then the next time you're going to do that just a mile and a half further along, and further along by the time you've summited or crossed the finish line. Remember, the summit doesn't define the mountain, and the finish line doesn't define the race. The graduation doesn't define the education. That's why we call it commencement. And in fact, the running is the reason, not having run. So I then said, okay, I'm going to do this, but I'm going to do it quietly in someplace else. And so while you took my bib for my 50th MCM and did a better job than I would do times 2, you crossed the finish line about the time I'd be thinking about getting to the half. I was out here on my nature trails along Rock Creek Park, and I ran alone, scaring only the deer and a couple of wonderful animal flora and fauna around me that are my constant companions. Flushed a couple of barred owls, and I said, it's the running and not having run the race. So my 50th might be the 51st or the 52nd or the 53rd, but it will be a 50th. And I do that because, yes, I have bumped into problems before. And when I say I have bumped into problems before, they were nothing, trivial, compared to those that were coming to the Marine Corps Marathon Hall of Fame dinner in my honor, whom right after I pinned on that number and ran what turned out to be the first of the Marine Corps marathons, 2 days later, a little bit stiff and sore, I had someone who is excavating the big tunnel that's underneath us called the Foggy Bottom Station, while they're blowing a hole in the ground in order to put the new Metro Center through, the bicentennial gift to the nation's capital. And periodically someone would have a tragic event there. And I had just come back from Harvard my mentor was Joe Murray. Joe Murray was the fellow who was my sponsor and mentor, and he got the Nobel Prize for doing the first kidney transplant. And I said, I know what good can come from a tragic situation, having done this often. And so I took out the kidneys from a couple of people who had tragic results from accidental death and put them into people. One of those people is there at my table, having just become the oldest deceased donor recipient on planet Earth. On the 40th anniversary, he was the eldest African American. On the 50th anniversary, there was no question. He was the number one leader. Another one with a liver transplant. Another one with, these are people whom I said, that convinced me. I'm not coming there masked or otherwise in the presence of somebody I put on immunosuppressive drugs in order to have them get the second case of this bizarre organism in North America. So I was disappointed, yes. And I want you to know that I did this because of a fiat. You will not contaminate those people. And what happened then was Alexander Hetherington sent me the MCM 50 blanket to say, you did it. And we know that you would have done it, and you will still do it, but we're just giving you this in advance because you're going to make the comeback. I said, could you talk about that after rather than before? But nonetheless, yes, I was disappointed. This was not so much disappointed in not running the 50th as in not running for 9 months sitting on the couch, which is probably harder on me than the therapy. I said it's a little bit like being on the colonoscopy bowel prep for 9 months.
Which was going to be, my next question for you was, you couldn't run that marathon, but how has the disease and the treatment affected your running abilities for the past 9 months?
They didn't want me to get my heart rate up. That would probably be one of the reasons that I didn't do it. I didn't try to run because remember, I had put myself in the care of some real experts. You, for example, and Joel Willis, my primary care, and the wonderful people that have been watching me from the TB control office. And when they tell me to do something, I was going to be a good little compliant doobie, and I did not attempt to run. So I'm not running. And that, I think, has been my biggest morbidity, is the deconditioning from not running. The drugs, certainly. I am very well aware. I'm not climbing on ladders to replace the bulbs overhead from the instability that I had from a couple of the agents. The cyclosporin particularly, they discontinued for that reason. And that's when they had put me on the anti-leprosy agents in order to take care of it. Fact is, yes, the disease itself, not so much. And morbidity, and certainly not mortality. The medication, quite a lot of morbidity, but I have a site ahead of me that's going to be discontinued now, and we'll see if I can't make the recovery. The third component was the deconditioning, and I recognized that would be something that I could just say, okay, I am now the ex-runner. I am a former runner. No, I am not a former runner. I am a runner who just happens to be about 200 yards behind the starting line instead of at it, and I will get back to it, but it'll be slower. And then once again, I have to ask myself, did I get all those degrees because I wanted the diploma at the graduation, or did I need the education that happened whether or not I took it for credit? Did I want the running or having run? I want to be the runner, and I'm going to return to running. And the medicines are now discontinued, so I have the freedom now and even the clearance from the experts, such as you and the others that are telling me, okay, go to it now. Enough about your body, it'll tell you when you overdid it. And so you will overdo it a time or two, then back off and keep on going, just the way you've done with every mountain you've climbed and the previous 185 of these 26.2s.
Yeah, exactly. And I think hopefully we'll see you at the Marine Corps in October. Maybe slower than usual, but hopefully you can do it.
I will crawl if necessary. I not only have you, and not only have my son, who's bringing a contingent. We're going to do a 3-generation marathon. And as you said, there are some family events. One of my nephews turns out to be the #1 quarterback in the college football program, and as a consequence, having been runner-up to the Heisman last year, he's going to be right on the cusp of that one this year. So we're going to go to those football games. We're going to see, and I think that's the important point, that I've gone through some struggles here, but look at the other people that I have treated and those around me who have had bigger problems with far fewer resources, and they've done it with an inner strength. Let me borrow some of that right now. And look at the young guys like my nephew or others who, of course, have a lot of people looking at him and sniping at him, and any number of them trying to knock him down. And he, too, is enjoying the game. It's not the prize, having that trophy at the end, because he really likes the sport. He likes the game. I like the run because the run is probably about the most perfect metaphor I've got for healthcare. It requires some very intelligent effort. It requires commitment, and it requires the personal and consistent obligation to look out for others as you are continuing in this race. It's not the finish line, it's not the graduation, it's the run. It's called living.
And saying that, how has the illness changed your perspectives on life?
Oh, so one thing, it was an abrupt stop to come up with, okay, you've done 1856 miles on your training log, and the next mile you're going to do is a year later. Oh boy, I'll do something about that. I'll try to do an end runner on that little law. No, pay attention to those who are better informed and probably have your interests in mind. Remember, there's probably one phrase I never want to hear from a politician or the others that are probably less informed than even they. I know what's best for you. Hey, wait a minute, you don't even know me. How can you possibly say that? I don't have to tell you what a runner's motivation. We're both to the manner born. We're preaching to that choir. I do know, however, that yes, this is something I shall return to, and I will be doing it. And it's only because I'm the only one that can stop me now. There's no drug therapy and there's no residual pulmonary malfunction of any kind. So as a consequence, it would be having the motivation pulled away from me. I won't have that happen, and that's the same thing I do with the students and the residents that I'm teaching, especially those that are from the developing world. I don't care that you don't have very many skills. That we can teach. And if you have all the skills, even some that I don't have, but don't really care about these people, and you're only trying to add another notch to your forward progress and get yourself out of this remote village over to the capital, maybe to Harley Street, and who knows, from AUH in Beirut up to University Hospital in U.S. No. Do you care about those patients, and are you willing to sacrifice some part of you in order that they thrive? These people aren't surviving. They are thriving. Even if their disease is progressive, they still have an art and a culture, and they sing and they dance, and they look out for others. If you can learn that from them, you have picked up a great deal. And if you haven't, this experience is wasted upon you.
Yeah, so how, and that's what brings me now to the next one, which is how has it affected the way you view your patients? I guess you just told me, I think it's more now you know what they've been dealing with and how they thrive with their disease. But what advice do you have for these patients, especially for people who are either suddenly finding themselves becoming patients or who are dealing with, as you said before, chronic diseases that are not, let's say, treatable as much as your disease was treatable?
Yes, this would probably be called a long-term disease rather than a chronic disease, because there is an endpoint in it, presumably. That is when all the organisms are dead, and there might be some residuum. But the fact is, there are diseases that I've treated all my life. End-stage organ failure, National Cancer Institute surgery branch, the oncology programs I've been part of, where I know, and they do also, that coming in is not likely to result with an eradication of that illness. So the question isn't, are we going to get rid of this illness? Is it, can we do something to mitigate it and maximize life potential? That includes even those that are treatable. So I would say, let's do what is possible, and at all times, focus on the patient. Not, I have a specialty, a little tool, this hammer of mine, means that you've got to have the appropriate nail for me to manage this. My thought is, how do we take care of the patient rather than saying, this piece of the patient is in my purview because it's my specialty and I can deal with this and I'm going to cure it, because curing of it is probably not the same as managing that patient's best interest.
because as you said, I think that each patient has their own life and their own interests, and always that's why we teach our students. You need to know what the patient wants, what their life is, before you decide on what's the best treatment option for them. You give them the options; they are the ones who make the decisions. And I think, my opinion is, people like you just keep a positive attitude about things, and I think you'll get through a lot of the diseases or a lot of the illnesses that you go through. Now, as a closing question, Glenn, if you could share one lesson from your experiences in Africa, one lesson from becoming a patient with MDR-TB, and one lesson from pursuing your 50th marathon, what would those three lessons be?
And the summary of the life, a uniform field theory, it is that living with purpose through illness or through challenges, there are many beyond the 26.2 miles ahead of you. There are many beyond a health risk. There are many right now that are being faced by a lot of folk. And that is, take care of yourself and also of those around you who are the ones who are going to pull you through this. It is a shared responsibility, and that life and hope are nearly coterminous. Have hope. There will be a resolution of this, if not a cure, eradication, at least a mitigation and a maximization of those other features that you have. So maximize those strengths. Do what you can to live life to the fullest, because each one of us is carrying a couple of sea anchors that are dragging us. This one, I think I'm going to cut those shrouds that's going to let that sea anchor fly. And therefore, I have no excuse to be morose about this. And think of that when I'm talking to patients who may not have that capacity to get rid of those burdens. So share the burdens that can't be completely eradicated, mitigate those that can, and push those who are dropping those burdens to newer and higher purposes. And with that, we can all live well.
Glenn, thank you so much for being on the podcast, and hopefully people have learned from a lot of your varied and wide experiences around the world and in fighting disease and running. Thank you so much.
And when I say there's a biography once written about me, and it really means what I'm about. These are gifts from the poor. Not that we have done something for them, but they come back to us and show us how it is possible to live without a lot of stuff.
Right. Thank you.
Thank you, Khalil.